Now we are going to live case. Dr. Saibalkar was supposed to do this, but in the last moment he had some issue. So we had a savior again in the form of Sai Satish, who is actually quite passionate about Mitra clip. Now he does this more passion than tower it looks. So we requested him and immediately accepted it. I think he's a person who has maximum experience in Mitra clip in India. I think thank you, Sai, for immediately agreeing for this and filling up for Saibalkar, who is of course your mentor and you did many cases together. We have Dr. Ramesh, Dr. Sushil, and Dr. Saurabh, Dr. Farang, and many colleagues, Dr. Manoj Agarwal, Purohit, and Hazra with me here. And we're sorry for slight delay, but I think now the floor is open for you. You can introduce the case and present. Sushil is also there in Zoom. Over to you, Sai.
Hey, thank you all so much. Thank you for the generous introduction, Srini. And I must say that's the first time I've done 2 live cases in one day. It's been a bit of a run, but always lovely to be with all of you.
And let
Sushil,
me tell you,
Saurabh,
you're the only
Ramesh.
one. You're the only one who's given this opportunity of doing live case, 2 live cases in ACVS at TCT. Nobody did this till now. Thank you. You should be thanking Saibal also for that. Thank you.
Anyway. I always thank Saibal. Okay. So I have a few air bubbles coming in from my SGC because I've kept the clip standing here while waiting for you guys. I'm going to quickly do the presentation. Of course, to my right is Dr. YVC Reddy. The ever watchful Vinod, who's the TDS for Mitra Clip, is right in between both of us. Karunya, Mail, Professor Chandra at Echo, and Ganapati. So big hello to all of you. And can I move on to the PowerPoint presentation, please? So the patient I have today is a 39-year-old male, coronary artery disease, old inferior wall MI, subsequent PCI to RCA in 2019, progressively worsening dyspnea since 2022. Now class 4 symptoms for the last 3 months. He's had 4 hospitalizations, severe functional MR, severe biventricular dysfunction, sub 30 EF as you can see. Can we move on to the next slide? This was the angio that I did last month. Play it. Why is it stopping? Back. Guys, play the angio. Forward. Wait. Don't move it. Yeah, there we go. Next slide. Perfect. So you can see the RCA. All the vessels are okay. Move to the next. So several points to discuss. Mechanism of MR. Here it's a restricted P2, pseudo prolapse of the A2. A2 overriding the P2 and a posteriorly directed jet. So we're going to go BICOM LVOT to locate the jet. Look at the grasping views. The length of the posterior is more than 1 centimeter. I know that you're usually looking for NTs when you're thinking of functionals, but in this case, because the posterior is so restricted, we have decided to start with an XT. This is also the new G4 that we have here. This is the 7th or 8th case we have done here, and I'm loving it. I'm refusing to believe there's a G3 in the shelf. So the 3D NFAS, of course, look at the location of the jet, the whole structure of the valve to measure the baseline mitral valve area, then the mitral valve gradients, pulmonary vein flow. What are our treatment options? Surgery, I think, is completely ruled out for this bad heart. You know the latest recommendations. A lot of safety for TER, role of hemodynamics, invasive measurements, which I always have. This is, again, Saibal's gospel. I never do these procedures without my pigtail in the LA. Ganapati, you're at 100% FiO2, right? Because I have a few bubbles coming in. I want to make sure you're okay. Okay, so strategy for this patient, given the central location, wide jet, long P2, pseudo A2. As a XTW is my first clip choice, and possibly packed with an NT if needed. What do you guys think?
Can you show us the echo pictures before we can talk about it?
Sai, I'm just going to move the clip into the heart, or you want me to show?
Sai, this is Saurabh.
Okay.
Do you assess their...
Hi, Saurabh.
When you offer Mitra clip to these types of patients, are you factoring in the COAPT criteria or the Mitra FFR criteria? I mean, the concept of disproportionality of MR to the degree of LV dilatation? Or are you thinking...
Saurabh, sorry, go ahead, you finish.
No, go ahead. I mean, that was my question.
Saurabh, no. So in most of the cases, I am looking at the COAPT criteria, Saurabh. But unfortunately, we've had to veer a lot because over the last 2 years, we've had some real interesting cases where I've had cardiogenic shocks. I've had large LVs, which are over 8 centimeters. Patients were on a transplant list. But there are certain rules that I follow as long as the right side septum is not overtly bulging into the left side, as long as my RV cath is okay, I still think these patients do very well. And before I go on, I'm seeing, Saurabh, can you see those bubbles coming into the LA? That's because I've kept the clip standing still in the guide for some time. I'm just going to move it in and free up whatever's there, and then we'll continue the discussion. And in the meantime, can Professor Chandra show the, that's perfect, Chandra sir.
Yeah, we see
Short axis, Chandra, sir.
VCTE on the screen.
Yeah. Are you seeing the fluoro as well? The echo as well?
Yes.
Yes, yes.
We're seeing the hemodynamic screen, the fluoro,
Okay,
and
good.
the echo. It looks great.
Okay, good.
Can you show us the 3D,
Okay.
3D echo?
No, one sec. Just follow the clip, sir. One sec. I have some more space. I'm going to move the guide a little back. I'm going to start giving M a little. I think I can. That's okay, right?
Yeah, it looks like you should clear it there.
So what was the height?
Yeah, I should.
Height
be
of
clear.
your puncture?
Yeah, there we go. Oh, look at the air. Look at the air, guys. Can you adjust the flow rate? Can you flow rate? Just one sec. Sorry. Flow rate, Vinod. Yeah. Sorry about the bubbles. That's because I was waiting for you guys, so I kept the clip standing for a bit in the guide. But I think we're okay. Okay.
Yeah,
The
I
flow
mean,
rates are
it's
okay.
not uncommon to see those.
Ganapati, 100% FI okay.
Sorry, before you
Okay,
go
good.
further, can we see some of the baseline echo images? Just to see what in terms
Yes,
of
please.
making it.
I'm going to leave it here,
a
Chandra sir.
decision before-
Can you show the baseline echo?
Do you have any recorded clips with the MR? Just so
Can
in
somebody
terms
give
of,
Professor
you know,
Chandra a mic? Hold a hand.
Okay.
That's the puncher. You can see it's mid fossa, nice and high. Even this, I got only a 3.7, 3.8. Chandra sir, can I see? They want to see the bicommercial and the. Yeah. There's the jet. Okay, that's your bike. Here's the bicom.
Bicom, I was,
Wide central jet. I think he's just scanning to get the
yeah,
pizza.
there you go. See here, I'm scanning medial and lateral.
Yeah, give him a mic.
With the Bicom view, since the posterior leaflet is retracted, P2 is retracted, you're seeing only the A2 that's coming over. So it's a fairly big jet, wide jet, and we have a Bicom at the same, I'm moving through it back and forth. Now, here is a grasping view. You see the same jet. Focusing on that, we brought it. And I think right now, patient has been well decongested. So as a result of that, his regauge volume is only 39 to 40 ml. Before it was about 80 to 85. So it has significantly decreased now. LV size has also become a little smaller. And I think we measure the posterior leaflet length. In the grasping view, it's about 11 millimeters to 12 millimeters. In the bicommissural view, I think the posterior leaflet, what I could get was from there and fourth chamber view, it's about 9 to 10 millimeters. Any question?
No, I think
Sushil,
this
any
is.
questions?
Sorry, go ahead.
No, I'm asking you. Anything else you'd like to see?
Oh.
Or shall I move the clip into place?
No, I think you can keep going. I mean, I
Here
think
is
these
the
are tough
height of
cases. The posterior leaflet
you can
is
see.
tethered, but it's not
And
fully
I'll show you
retracted.
one last picture quickly of the.
Yeah. So that is the reason why, Sushil, I'm taking an XTW. I'm fully...
Here, you guys can see the Bicom view and the explain of the same, almost LV grasping view simultaneously. That's the biggest jet. So the patient is so much decongested.
Okay.
It becomes
Chandra sir?
Yeah.
So can I see a Bicom and explain of my clip? So I'm going to try and move over the valve. Sushil, I'm just going to go forward because patient's been... is that okay for
Actually,
you?
in myocardial
Saurabh,
infarctions,
all
the
good?
gap between two leaflets is very small in comparison to DCM. DCM have a more wider gap because of large ventricle. Out here, it's very advantageous to have a small gap
Chandra
between
sir,
two
Bicom?
leaflets because it is just recent MI.
Yeah.
So this is the ideal case for clip.
Yeah, I think, in these functional MR patients, our strategy is to just look at the posterior leaflet because that's really the deciding factor on the technical feasibility. Everything else you can get because they typically tend not to have very wide coaptation. When that tends to be if you have a flail and then you have a really big gap.
So explain on the
And even that with the XTWs, that's less of an issue. You can sort of start on the side and zipper it.
more M.
Another problem is
And the point that the
Move the
MR
curve.
is dynamic in these patients. Although the regurgitant volume is 40 cc's, the regurgitant fraction is probably still high.
Explain the
that'll
clip,
be
Chandra sir.
so reduced. And it's dynamic, so it's not surprising that, in an intubated patient with decreased afterload, it might be a little bit less than a baseline.
Too much.
and post-MI MR, the LA doesn't get time for the remodeling, so you don't get enough height of your clip versus the AML height. Whereas in dialectic cardiomyopathy,
sir,
LA is very big, so you always get the
Why come?
advantage of larger height. So it is one way difficult to do inferior MI, but advantages on the coaptation, small coaptation gap.
Yeah, it just depends more on the LA size and more on the height of the puncture. And to gain height at the septal level, of course, not as much from the inferior part, but from the posterior part. So if you think about the plane coming through the IVC, the more posterior you get, the more height you gain above the plane. And then, so typically it'd be a little inferior, but as much posterior. And then when you see the tent, not on the screening as much, just when you're doing the procedure right in the beginning. In the screening echoes, all we really look for is if the septum's hostile or not. Other than that, you can make it work. So for example, even if you can't get too much height, you can use your A and P knobs to gain some height or shed some height. You're saying something, Sushil?
No. The only thing is it's functional, so you also gain a little bit of height because there's some tethering. It's not terrible, but you probably gain another half centimeter where you're grabbing is below the annulus. And then, you typically will measure the valve area on 3D. The valve area on 3D looks pretty big. And the question is, are you going to put one or two clips? I think you have to make that decision. I know I've had this discussion with Sai before. In functional, I get nervous about XTs because the stretch on the leaflets when it's tethered. But I think there's two different camps. I don't think we have the answer here. But if you're thinking of putting two, you might be a little bit. The jet looked a little more medial as well, so you might be a little bit more medial side of P2 when he puts that first clip.
I'm having some challenges with the view, Sushil. Sushil, even I'm a little uncomfortable about using XTs in functional. Yeah, so even I'm a little uncomfortable. I was just lining it up. There was a little medial dive. If you notice, I corrected it. I'm looking okay now. So coming back to what you were saying, I'm also very uncomfortable with using XTs in functional, Sushil. But the problem in this case is that the PML is so retracted and bent down that I'll be struggling forever to be able to get it and the AML in one shot. Now, as long as I go nice and posterior, and as long as while I'm closing the clip, I make sure the clip arm is under the posterior annulus, I won't be pulling it too much, and I think I can manage to safely close this clip. I've struggled with NTs, I've taken them out, I've put XTs and a man.
Yeah, I agree with that too, Sai.
So,
and
I
I
like-
personally, I just look at how broad the jet is and then use my decision just based on that, on what type of clip to use.
And another thing, in ischemia, maybe one clip is sufficient,
I think
Small
that
annulus.
angle, I think that angle is
rather
looking,
than
guys.
two clips.
Yeah, and I noticed you've
So
done
I
this
think that
on
angle
2D,
is looking nice.
with X-Plane. I've been using more and more 3D NPR for trajectory because the key part of MitraClip is trajectory. Here it looks good, so I think you're fine. But NPR is nice, and that sometimes it gives
I like the
allows you to
trajectory,
make your
Sushil.
trajectory
Look at the way it's coming
Yeah.
in. It's almost at right angles. Chandra sir, can you show me the clip? I'm
and
just going to check the
Flora
trajectory.
and Flora's a nice clue
The
as
medial
well.
di-
And on Flora, it looks
See,
like
the medial dive is gone. I'm having a little bit of bubbles coming in. I don't know why.
I think you
But,
probably
I think
have the
that's the
drips
flush
in the
rate. I will
back
manage
turned
that.
on quite a bit, Sai. If you turn down the drips, that's
No,
probably...
no, they're okay. It's just no, Sarab. You know what? I had this in the SGC for some time. I think we're okay. Shall we go ahead? Shall we check 3D enforce and check? Are you happy with the trajectory, guys?
Yeah, I like it. I think...
Show us the 3D first.
Yeah, no, first, before 3D, Chandra sir, can you put the color and see if I'm splitting the jet in BICOM? Probe up a little, Chandra. There you go. And retroflex a little. Yeah, very nice. Probe up a little. Probe up a little.
Become more medial.
Yep. Can we see color now? Yeah, it'll come. I'm going to understraddle a little so that I get a little more height there.
That might be a little better because you had a little bit of medial
So
dive.
usually when I'm
straddle, we'll fix it, make it go a little bit more lateral, so that'd be helpful too.
That's exactly
good.
why I did that. I just pulled it back a smidgen.
What,
And you know, when we are in AP like this, in hearts like there.
Sai, what
I
tidal
think maybe I have to
volume
go a
are
little
you at?
posterior. There we go. Ganapati, are you going at 50? What is the tidal volume? 250. He's 250. That's good enough. That's low enough.
Low. Yeah, yeah.
No, that's,
He's-
So
that's
for the
70
audience,
kg
generally
guy.
do low tidal volumes to prevent respiratory variation. So that's what they're discussing.
So can we see if I'm bisecting the jet because these bubbles are...
To reduce the
Out of
saline,
range.
maybe it's due to saline.
I already have. There we go. Okay. Okay. Reduced. Okay. So I think I'm right at the jet.
Yes, your mouth
Can
of
we
the
go
jet.
to 3D NFOS? 3D NFOS? I'll start opening the clip.
So you're gonna, yeah. By fluoro, it looks like you're
Goes up.
oriented well, so that's good.
Close it. Yeah. Unlock the clip. I'm just
You have
going
to
to speak
adjust
what
the
I'm doing.
3D
so-
gain. 3D gain you have to adjust. We can't see the leaflets.
I can't tell yet
One
whether the
sec,
clip
it'll come.
orientation is good.
I've not opened it yet.
No, 3D
One
echo
sec,
gain. Yeah.
One sec. I'm going a little anterior. We'll adjust the gain, Chandra sir. Can we adjust the smiley so it's a little turn to the left so I have it nice? Ah, lovely. Perfect. I'm going to counterclock a little. I'll open to 180. See, now you see it's such a wide clip, right, this XTW?
Yeah, for the,
So
for the
I like it
XTWs, I
actually.
don't
Look at
even open them all the way. I just leave them at less
Yeah,
than
I
180.
haven't. Look at the fluoro. It's about, yeah, so it's less than 180. Do you like it? Vinod? So I don't move forward until Vinod nods his head in that ominous way. You like it, Vinod? Okay, good. He's happy. What do you say? Close and go down?
I think it's good. I just don't see the leaflets well. Where is the commissure, do you think? Where is the
Okay, one
commissioner
second.
line? That's what I'm having there.
Chandra sir? If this is okay, can we go back to BICOM and BICOM LVOT? Why is the LA pressure shot up? Has the blood pressure gone up or am I hitting the valve? See, I'm hitting the valve. Okay. Chandra sir? Yeah.
I mean, just looking at these 2D images, it
hitting
seems
the
that your
valve, right?
orientation is going to be pretty decent there.
Yeah. Can you explain the clip for me, Chandra sir? I'm tenting the anterior mitral leaflet, so that's why I'm going to go posterior to relieve that. See, the pressures came down a little. Okay. Now I'm just going to check the tactile on the grippers. So my tactile is on the anterior. See, tactile is on the anterior there. Yeah, big posterior.
Posterior.
Yeah, I'm good.
posterior.
No, tactile is on the anterior. Yeah. Tactile is on the anterior. I'm good, guys. Come on, let's go. Close. Yeah. Close.
So I don't know if you do it. I like to adjust the fluoro to be coaxial now. That I know if the clip is rotating, I'll know by fluoro that it rotates.
Areo.
You don't have to do it
You're okay
the
now?
way you normally do it. I'm just saying those are.
Okay, don't worry, Sushil. I'm good. Just that's enough for me. I like it like this, Sushil. Chandra sir,
Okay.
can you explain the clip for me? Make sure I'm still in the jet. Let's do a 3D enforce and then I want to go in. Okay. I'm right at the jet area. Good. Can we do a 3D enforce to check my orientation? Ganapati, you're happy with the patient? Okay. I'm going to counter clock a bit. Clockwise or counter?
Clockwise.
Clock.
Clockwise, I think.
If you're going in P2,
Chandra,
if you're going
sorry,
P2,
I just need
clock.
Chandra sir, I need the image. I need to see the arms. There we go. Okay, I think that's okay.
Yeah.
I like it. Sushil?
I
Saurabh?
agree.
I like it. I mean, I wish I'd just
Chandra sir, probe up a little.
see a little bit more of the orientation, but I think we're splitting hair. It generally looks pretty decent. But I don't see the leaflets as well, so I don't have a
Okay.
great sense of commissural anatomy.
I think it's going to change a little as I go in. We'll adjust on the fly, guys. Shall I go down?
Yeah.
Chandra sir, Bicom LVOT, please.
We can't see the leaflets, Satish, on the 3D. Neither A2, P2, A3, P3, nothing is in. So all we are seeing is a circular thing.
I know I'm having a challenge with the imaging. Chandra sir, can we do something about the imaging? Ganapati, why is the LA pressure gone up?
You can reduce the gain of the 3D so that you can see some tissue.
I mean, part of it is your echo probe is imaging right down the.
I think it's a part of it is the
guide.
heart is a little rotated. Yeah.
Yeah, so I would go either a little deeper or a little with the echo probe, so you're not imaging right through the guide because you're shadowing yourself. And see if you can find it. You know, sometimes it's just a
So
narrow window that you can get the images.
How many more minutes do I have for the case?
22 minutes.
Okay, good.
We have plenty of
Srinivas,
time.
I'm doing
Shall
your
we,
job.
Chandra sir, if I can see the,
Srinivas, I'm doing your job.
if I see,
I'm doing your job.
okay. But they can't see the leaflet, but it's okay. I don't think we can see the light.
I think if you explain off of that, we got a pretty good idea of. So
See, I have so many shadows here. I'm not able to see my.
I believe the T probe, the shaft is in the way of where you're imaging from. I like Sushil's suggestion of maybe going
Yeah,
just
yeah.
a little up and see if you can image it from there.
You want to go a little higher, Chandra sir, and image it from there? A little, me? There?
Actually, he got 3.5 height. Should be at least 5 millimeter height so that it becomes much easier to navigate.
So the heart is large, the heart is rotated. We're having some challenges here with the imaging, but I think I should go into the LV now and maybe he can go up and down with the probe and see if he can get me my grasping view.
Let's go and dive.
Yep. Okay, there we go. All right. Sushil, what do you think?
Yeah, I think
Just
you can go in the LV.
one-
Just
one
don't,
shot
I
with
wouldn't
colours and
open until
Russell.
you can see the image. Yeah.
No, no, I won't. Color, am I at the jet?
So you, on the jet right now, you have to
Perfect.
go more
This
medial.
is posterior, right?
But he
See,
should
the
be going
problem
more
is I'm not
medial
able to
if he
see the
goes,
full the problem is I can't see the full extent of the jet, and I'm grasping for strings on my view on the LVOT.
And anterior. And anterior.
Chandra sir,
He's
can
with
you
anterior
can you
both.
anti-clock the probe and get the jet for me? Okay, we're just going to wait till he gets it, and then I'm going to go in.
Sometimes the imaging is the most challenging part of this procedure. I think it's so imaging heavy.
Yeah, you know, we would have finished by now, but suddenly we lost. I've just put a water bag or something under the shoulder. That's okay. I think that's the best we'll do. Is that okay? Much better. Chandra, I like it. That's good. Ganapati, stop doing what you're doing. Okay, yeah. Okay, all right. So am I at the jet? Okay. I think this is the best he can get. I'm not going to hang around. Enough, Ganapati. Okay, Vinod. Can't see. Can you explain the clip, Chandra sir? Okay, that's better. Okay. Yeah, I think so. Can you just see if I'm at the right place, Chandra sir, with the color? We never anticipated the imaging to give us so much trouble, but all in the game, right? Okay. I'm going to start going in. Is everybody okay with that?
Yeah, no, I would think, yeah, and I would just look on fluoro as you go to make sure you're not rotating.
Yeah. I have a little bit of a medial dive. Can you see that, Sushil?
Yeah. Although, no, I'm not sure. Some of the view looks different now because the LV is really foreshortened there.
Like this? Chandra sir, I need to see the clip. Yeah. Okay. Good. Okay. Can you explain the clip for me? Yeah. Yeah, wait. Before that, let me just put the color. Okay. Okay. Can you get off color, Chandra sir? And explain the clip for me so I can see the clip arms.
So the fluoro.
3D enforce.
Show us the fluoros.
Fluoro's on, guys. It's live.
And now we see that.
3D enforce to check my clip orientation. Guys, I'm having to improvise because the imaging is really bad. I don't want to hang around here.
I would counter a bit now. If you see, it looks like you need to counter a hair.
Chandra sir, pull back the probe. Okay. That's okay. I can't see. Okay. Later. Okay. Okay. Can you show me I think it's okay, right?
Orientation's okay.
Orientation looks okay. Ganapati, wait. Okay. I think I'm okay. Can you explain my clip, Chandra sir?
Lower the clip and see the jet again.
I can't see.
Interiorly, it is completely shadowed, unfortunately.
Yeah. You know? Chandrasa, I need to see
I
the
would
clip,
check it.
Chandrasa.
I would
That's
check
better.
another
That's better.
That's better.
Much better. Yeah. I want to open a little more. Okay, Chandrasa, can you just see a 3D if I want to check my orientation? See, this heart is so rotated. I think the orientation looks good. Drop the gain. Clockwise a little.
Yeah.
Huh?
No, I mean, you're a little bit on the medial side, so it's probably not terrible. But a little clock would be nice, but
I'm doing it. I'm doing it. I think that looks okay. Okay. Can we go back to, Chandrasa? Give me a nice view of just once. There we go. Sure. Okay. 1 minute, sir, just hold on. No, don't, just. So my posterior, sorry, I can't see the clip, Chandra, sir. Yeah. I can't see the clip.
I think you have to go back in because the anterior leaflet came above and it's curled.
Yeah. Okay.
There, now the anterior is starting to go.
Now it looks good.
No.
Put the leaflet.
No, it's curling again, yeah.
The leaflet is curling again. You want me to take ventilation off, guys? It's bouncing too much.
The only issue is, and you're a little
Better,
loud, so it's probably
better.
okay. We'll take you a little bit medial. You can do a breath hold. We'll take you medial though.
Guys, Chandra said, just show me the clip. Are you okay with it?
You can go for
Is
a
the posterior
30-second apnea on the ventilation.
I know. It's in, Vinod. It's in. Just. Okay, can you check now how it is?
Put some color here.
Is the posterior enough of the posterior in? Oh boy, this imaging. Today we are having a good day. So I have the anterior in nicely, Sushil. I'm not convinced the posterior is in.
Yeah, I'm not either. Do you want to open the clip a little bit
raising
more
the
before
gripper.
you lift the posterior?
Chandra sir, just hold it like that. Yeah, that's what I'm doing.
That's good. No more
Chandra
than
sir, show
that.
me and explain.
So
I
you
want to
see
the clip.
it. So maybe go a little posterior before you lift the gripper, because it looks like you're below the posterior, which is good. Just a touch. I think the clip closes it a little bit because you're at 180. You're going to lose the anterior.
I would
Maybe close it a little bit.
I would close the
Close
clip
it
a
a little
little
bit,
bit. I think the posterior will fall into the V.
I've done it. Oh,
No, you're inverted.
sorry, I'm coming back. Sorry, just coming back.
There you go.
Yeah,
there you
go for it. Posterior's in. I'm going to go little anterior. No, anterior's off. There, anterior's in. Posterior's in.
Go a little posterior and come up. Don't lose posterior because it's so tethered.
That's what I'm
If
doing.
anything, good. Now come up. I think you're good.
See, if I go
Oh,
posterior,
no,
I'm losing
lost
the
anterior.
anterior. 1 sec.
Just curling.
Yeah, I know. 1 sec. Wait, guys. You see that? I've got the anterior
That's
now.
good. You can drop
I
here.
think
and
I need to
optimize
give a
out.
little minus.
And I think here it'd be easier to optimize the anterior afterwards rather than the posterior. Because if the posterior
Yeah,
curves
so
and
I'm going
doesn't
to
go
grab
to
the
the
posterior.
V,
Chandra sir. Okay. We're okay. We're okay. Don't
I
worry.
like your idea. I like
You
your
got the
idea of a little
posterior.
minus, though. That's not a bad idea. Yeah. Now you got both. You
I'm
got
going
both
to give a
right there.
little minus, which is what I've done. I know.
And you
I
got
gave a little
both.
minus.
Just come up a little bit, and you got both.
that's looking good.
There you go.
I have both.
You want to drop there? Yeah, good. The minus took you a little lateral, but it might be
Chandra
okay.
sir, I just need to see.
In functional. Yeah.
I think it might be okay. Ganapati, you can ventilate. I'm just, Chandra sir, I need to see that posterior mitral commissure. Yeah, perfect. Can you put the color? So I just, because a wide clip and it pulls a lot. There we go. How's it looking, guys? No, before I tighten, the one more thing I want to mention here is if you've played with the clip, you realize that when the grippers fall, they have these shark teeth and they're like little meat tenderizers. And when you finally tighten is when they clamp down on the mitral leaflets, and these are bad leaflets to begin with. So I don't like closing the clip fully until I know that I have enough posterior, which I can see I have here. I have enough anterior, which I can see I have here. Now let Ganapati ventilate, patient is nice and stable. Ganapati, you're happy? Okay, now let Chandra sir get all his views and we are in no hurry. And once he's absolutely happy, then I'm going to start tightening full hog. What do you think? Sushil, Saurabh, now I'm relaxed, I can talk.
Yeah, I like leaflet insertion so far. I typically like that
Yep.
plan just to go, and even before we get there, I would like to walk into the clip both from the medial side and the lateral side, and also get a formal assessment of, especially if the posterior leaflet is all the way down to the V. And then obviously
See, you can see the LA pressure from 57. From 57, it's down to 39. And that's without my clip closed. Even when you look at the angle, it's a nice angle. Look at this view. I love this view. You can see the guide coming in, a nice perpendicularity towards the valve. Pressure shot up from 90 to 120 here hemodynamically.
Sushil, what will be the
So I'm going to just Ganapati ventilate at
SLD
250.
rate of ischemic versus non-ischemic MR? If you have a ischemic MR due to like mitral infarctions, the
Chandra sir, can you see
SLD
leaflet
rate will be
insertion?
much higher.
Yeah, because you have tethered posterior leaflet. You're right. But that's why it's,
Very nice,
I think Kasai's doing and doing time
3D
to take,
enforcement
make sure they
Chandra
have
sir.
good, as much leaflet as possible.
You're happy, insertion?
just humor me and walk into the clip from
Surab,
He wants you to do explain medial to the clip and
Can you-
slowly walk and move it slowly towards from medial to lateral.
Yes,
Slowly
so
across
not-
the clip and explain.
that's right, not
Yeah,
in
yeah.
3D,
Yeah, yeah.
just in 2D explain.
I'm
So get the
but I
get the
I'm-
commissioner view. And then, yeah, more.
I just
Sorry, go
want-
ahead. Sorry.
Sorry, no. I just wanted to make sure that I was okay in 3D first for a second, and then he could do the scanning back and forth. I just want to do the leaflet insertion assessment, Chandra sir.
So until unless you
Okay.
go for the bicommissural view, it will be very difficult to grasp the posterior leaflet. Because anterior leaflet is quite long, the posterior leaflet is very small.
Can you go to? What next? So we have done LVOT BICOM. Let's just see the 3D enforced, Chandra sir. Saurabh, I have what you asked me for. I'm coming to it. Just give me a second. Chandra sir, 3D enforced.
I mean, so far it's looking really promising.
Yeah, I like it, Saurabh. It was very difficult with the views being so bad. You know, what really helped was sticking a couple of IV fluid bottles. Here, I just want to look at the tissue bridge. I want to make sure it looks good enough. Sushil, now do you know why I took an XTW instead of a conventional NTW? I would have been here till tomorrow morning if I tried doing this with an NT, right? Because the posterior was so tethered and tucked in. And even with an XT fully
you're
open,
right.
I had to like...
I think because you had enough leaflet, it's okay. It's important to keep in mind the last two rows, the XT has 6 rows of those tines, and the last two don't have as much radial strength. So if you don't get all the way to the V, then you might not have enough grasp. But here you look like you're all the way down, so I think that's good. Medial lateral, I think you were initially a touch more medial, but I think it's still okay. Then the other thing with the XTW that you're looking at, as you just pointed out, is make sure you're not maloriented, because the clip is so long that if you're not in line with the coaptation plane, you can torque the leaflets.
Totally. Why do you think I constantly kept looking at fluoro? Sushil, but just look at the hemodynamics. I've only closed 60 and my pressure is down from 58 to 33. BP is over 130 now. So the heart is loving whatever we have done. I like the tissue bridge. You guys are okay with it? Shall we move on?
Yep.
Yeah, no, this looks good.
Chandra sir, can I have LVOT? Bicom LVOT, so I want to see my clip so I can release the tension as I'm going to tighten as I release the tension. Chandra sir, explain the clip. Yeah. There we go. Go down a little. Oh, look at that. Look at the amount it's pulling on this. Oh, this clip is like a truck, this XTW.
This is very nice tracing of your LA pressure simultaneous. Do you see that? That's beautiful.
Yeah. Lovely, right?
Yeah.
Yep. Chandra sir, that's fine. I don't want to tighten too much, but I like how it's looking. I've released the tension. Look at the LA pressure, guys. 57 to 17.
Yeah.
Don't you just love this?
Looks great.
Okay. Chandra sir, now can you do another leaflet insertion?
You're not going to put color on? You're not going to put color on? You're just going to hold us in suspense?
I'm going to Chandra sir, color. Look at the hemodynamics, guys. Look at the hemodynamics. Look at that.
Look at the color. See? And what's the mean LA pressure pre and now? So what did the mean LA do? Because I think to me, that's one of the biggest factors, what the mean LA pressure does.
So the mean LA pressure went from almost 29 to 11 now.
Yeah. So this patient's going to do great.
So if you look at the tracing on the screen, look at the tracing.
Yeah.
Look at the tracing. When it was 52-14, it's...
This will be a wonderful result and he'll feel a lot better.
So the key component is there enough leaflet insertion, which, you're all the way to the hub on the posterior, you're into the annulus. You had 10 before, so presumably you have all 10 in the clip, right? In the XTW, ideally you'd like to get at least 9. And so you looks like that's what you measured on the posterior, and you're all the way to the annulus, so you should have all of the posterior. The anterior we saw well. You can measure what you had outside, but the imaging is difficult, so I think it's challenging, but overall it looks good to me.
And you also saw, as you were tightening, that the mobility of the anterior leaflet went down fairly dramatically, and the posterior leaflet was rock solid right from the get-go. So I'm liking it. We haven't checked the gradient, or at least I missed it.
No, we haven't checked it, but I'm just looking at the insertion now still because I want to make sure I want to let this baby go.
Yeah.
But look at this. Like Sushil said, I'm all the way tucked into the posterior, but I didn't have a choice. You saw, even if I veered a little away from the posterior, I kept losing it because it curled down. And I think I got enough anterior. It's nice and stable right now. The LA pressures have crashed. Look at that. 14.8 now. It's getting better and better. Blood pressure shot up to 130. So I think whatever I do, whether I pack it with another small NT, if I have place or no, I still think he's going to do really, really well.
I'd probably check the gradient.
How many more minutes do I have?
1 minute and 30 seconds according to Srinivas.
Oh, lovely. So on time, ready to tango. Chandra sir, gradient, So then we can let them go and let the clip go.
Yeah, I do want to see the gradient.
And again, if the
We
mean
have a
LA
couple of
pressure is down
youngsters
that
watching
much,
the case
I
as well.
really,
Can you see that?
I honestly don't. It doesn't matter to me what the gradient is. If the I know it's going to be low because the mean LA pressure is 11, right?
Has just dropped. Yeah.
I don't even feel that you need another clip. Like I would
Yeah.
just take this.
I might not put it, Saurabh.
Yeah.
Yeah, I'm all ready.
This is a beautiful
But I
result.
just want to do the drill, otherwise Vinod. Thank you, Saurabh. See, I have to do all this, otherwise Vinod will peer at me through his glasses. So now I got to do this, I got to do pulmonary veins.
This looks really good.
It looks lovely. நல்லா இருக்குல்ல sir? Nice and stable. Don't worry about it. See, look at that. I like it when the whole system is moving with the heart, but I have to let it go to see it anyways.
The LA pressure seems even better, yeah?
No, you look at that. The systemic pressure is now at about 110, 126, and my heart rate has come down to nice 67. LA pressure has crashed from 57 to 14 Bs. So he's going to feel a lot
Why don't we
better
measure
when we let
mean
this go.
gradient, look at pulmonary vein, and then deploy?
Yeah. I still will do one more round of insertion, Sushil. Because
I'd say check thrice and release once.
6 and 2.
Okay, good.
Yeah. That's perfect, Saurabh. Hey, so I'm going to say bye to all of you. I think we have run out of time, right?
Yeah. Please, I think you can deploy, and then we could clearly appreciate how LA pressure decreased, how things you've demonstrated so well. I think we just want to see.
So thank you, Srini. So look at that, mean gradient of 2. So I still have space if I find a small little... See, unless I find something that I'm really concerned about, I'm not going to mess with this result.
Right.
Look at my LA pressure now, Saurabh. 12, 7, and 8. It looks fantastic.
Yeah, this
The
patient
leaflet insertion looks great. I have enough AML in, right?
and this patient will feel a lot.
I have enough. Yeah. So I'm going to say bye from Team Chennai. Quickly, Dr. YVC Reddy,
Hi.
Vinod. Come into the frame, Vinod. There you go. Vinod. And we have a couple of young medical students who are aspiring to be structural interventionists there, Uddhav and Harish. We have Ganapati, Professor Chandra, and the whole team from Chennai. Thank you so much for having us. I know that nobody could fill Saibal's shoes, but I hope I at least kept you a little entertained and did justice to my guru.
I will text Saibal and let him know that you surpassed him.
Thank you, thank you, Sai.
Don't do that. Thank you.
Thank you, Sai, for a great
Thank you,
demonstration.
Thank you all
Take
so
care.
much.
Great job.
And I'm very happy to say that the hall is
Bye,
even
Sushil. Bye-bye.
full even now at this time. And I like the interest of all the doctors who are staying till so late. And I'd also like to mention that about 120 doctors outside India, South Asian countries, have also watched you, because we are streaming this in 5 hubs across outside India. In India, we didn't want to give Zoom links because to encourage physical
Fabulous.
attendance. Thank you all, those who are watching on Zoom and all those
Thank you
colleagues
all
who
so
are
much.
sitting
Thank you
here.
all.
Great demonstration. We had a good number of cases, and thanks for filling up at the end. Thank you, Sai. And we should be extremely thankful to Sushil also,
Bye,
who has
bye,
been
bye, everyone.
throughout sitting, though it is night. Thank you, Sushil.
I don't even know how he does it.
Yeah.
I don't know how he does it.
And thank you. Any final words, Sushil, because you're anyway there?
No, it was a great day. Wonderful 8 hours, more than 8 hours of live cases, talks, discussion. I thought it was wonderful. I'm just sorry I couldn't be there in person. And I want to thank you for allowing me to join via Zoom. And I miss seeing all you guys, and hopefully see you soon, though.
Yeah, we are able to, we are waving hands. Thank you. And thank you all. And request all of you to join. We'll enjoy cocktails and dinner here, Sushil. You take some rest. Thank you.
All right.
Thank you all.
right.
Thanks to Srini, I couldn't come. Bye.
Yeah, you did a fabulous job there. If you have time, you can join us tomorrow, right? Thank you, and thank you all the
Done.
colleagues here.
Bye. Bye, guys. Bye, Chapin.
Thank you. Bye-bye. Yeah.